Hi, everybody. We'll go ahead and get started. Thanks for joining our webinar today. We're excited to continue the Hepatology and Liver Transplant webinar series. Lindsay, thanks for your help organizing this. And Lindsay Carter is going to put some information in the chat about claiming credit and MOC points for this. Today's talk is by my colleague, Dr. Rice. He's an assistant professor of medicine here at the CU School of Medicine and one of our transplant hepatologists. He is also our expert within our group on Wilson's disease. And so he's going to give us a great talk today on diagnosis and management. John, thanks for doing the talk and take it away.
Of course, thanks, Avash. Before I kind of go into talking about Wilson's disease, which is the ever-present disease that we think about and rarely diagnose, I just want to put a shout out to the Rocky Mountain Highlights for GI and Hepatology, which is coming up on August 15th. It's free registration. It's great talks from people in the division here on all different topics. So I encourage everyone to sign up and join for that. So today we're talking about Wilson's disease, and really a lot of our main goals in seeing who's in the audience is really understanding how to identify presenting symptoms and signs of Wilson's disease. So obviously we'll talk about this, but it's a rare disease with a very broad presentation. So it mimics a lot of different things. And so we have to know what to look for and when to look for it. But then also how to then interpret the testing and results so that we know what to do stepwise and then ultimately when to refer to a hepatologist to help kind of finish the workup and initiate treatment when the time comes. So starting off, what is Wilson's disease? Obviously, again, it's talked about a lot, but what really is it? Well, wrong Wilson's disease here. This is going to be the correct Wilson's. This is Kinnear-Wilson. And it's interesting that the Wilson here, which also has a lot of psychiatric overtones, has the same stare as Kinnear-Wilson. But he described progressive lenticular degeneration, which eventually became known as Wilson's disease. And he defined this in the early 1900s. And he identified ultimately that copper, which is what we think about when we think about Wilson's disease, is copper problem, copper overload, is the cause of this. So when we think about copper, a lot of people think about their lead pipes, or sorry, their copper pipes, their copper cables, their batteries. But why does this in our body and how does it get there? And so copper is a dietary element, essential element that is used in a lot of tissues for enzymatic processing and other important tasks. And so copper comes in through many different forms, which we'll talk about in the treatment form. But as you see here, there's a lot of common things here: Parmesan cheese, mushrooms, seafood, sesame seeds, beef. And so it's ubiquitous in a lot of things that we eat on a day-to-day basis. So it enters through enterally through our diet, and we take in about 0.5 to 2.5 milligrams per day of copper. This is absorbed in the duodenum in the small intestine, and then it's transported to the liver via portal circulation on albumin. There, it's incorporated into ceruloplasmin, which we'll talk about, and using an important enzyme called ATP7B, which we'll talk about. And then it's excreted into the blood where it's transported to the tissue where it's utilized in its tasks. Excessive copper is then excreted into bile by the ATP7B, where it then exits the body through feces. And so you can see here, interruption of the ATP7B by Wilson's disease interrupts this transportation and delivery of copper, as well as the excretion of it. So what is ceruloplasmin? Obviously, this is a very important protein in Wilson's disease and in the pathology associated with it. So in the hepatocyte, copper is loaded onto protein known as apoceruloplasmin. This is done again by ATP7B enzyme, and this transforms apoceruloplasmin into ceruloplasmin, also known as holoceruloplasmin. Patients with Wilson's disease are unable to make this transfer, leaving unbound copper in the liver and eventually in circulation. So Apoceruloplasmin, interestingly, has a shorter half-life than holoceruloplasmin, and this leads to Wilson's disease characteristically low ceruloplasmin level. As you can see, there are other conditions that do lead to low ceruloplasmin, and some of these being things like copper deficiency, as well as cirrhosis, and then some rare genetic diseases, which we won't get into too much today. This is why it's important to know the next steps when you're ordering a ceruloplasm, just because we know that other things can cause it, and it's used as a screening test. Interestingly, I've actually had a couple few patients recently with high serum coppers and high ceruloplasmins with otherwise negative Wilson's disease workup, and this is likely due to systemic inflammatory processes or hyperestrogen or pregnancy. But I've had a few of these consults recently. So kind of getting into the just general epidemiology of Wilson's disease, it's a rare disease, as we all know. About 1 in 30,000 is the estimate in the United States. However, true numbers are not obviously known. And this varies, though, by region. Certain parts of the world where consanguinity is more common practice, that this rate can be much higher. It's autosomal recessive, and it has about 600 mutations. And so we'll talk about this a little later on with genetics, but most commonly, people who develop pathology are compound heterozygotes, meaning you have two different mutations together, not the same one. ATP7B, as we talked about, is ATPase copper transporting beta is important for biliary copper excretion, as well as binding copper to ceruloplasmin. And this copper accumulation then occurs in all over the body, specifically, obviously, the liver, hence why we're here in hepatology, but as well as the brain, eye, kidney, heart, and it leads to oxidative stress and direct inhibition of protein. So to kind of put this all in the context, because these are patients that you guys are seeing, just kind of giving you a sense of the patients that come through to us and when we should think about this. I'm going to use a clinical case or a patient I actually saw last year, and what kind of takes us through this process. And so this was a 19-year-old female who initially presented to her primary care doctor after her freshman year in college. She was healthy, with only past medical history being some mild anxiety and depression in high school, which improved after therapy. And some routine labs just showed an AST of 45 and an ALT of 55. Looking back through her records through her pediatrician, that this has had some mild elevations over the last couple of years as well, and kind of a similar degree and pattern. So elevated liver enzymes. As far as some other additional history, she had no symptoms, no new meds, no high-risk behaviors, rare alcohol in college, and no drugs, and no other atypical exposures or travel or anything like that. And so we have a patient now with some elevated liver tests. Nothing's really coming back from an HPI standpoint. What other things, if we were to be thinking about Wilson's disease, should we be thinking about? And it's hard because, as I said, Wilson's disease has a large spectrum of presentations and can be a mimicker of a lot of different things. And so putting in kind of two main big buckets that we'll talk about now are presentations, specifically hepatic and neuropsychiatric. And specifically for hepatic presentation, this is the full gambit of findings that you might find when you're working up a patient or just getting routine labs or imaging. So hepatomegaly, isolated splenomegaly, elevated AST and ALT as it was in this patient. Hepatic steatosis is a common presentation of this. So patients with steatotic liver disease, this should be considered in. Autoimmune hepatitis mimic, it can look like it both in labs and on biopsy, as well as you can present with cirrhosis or advanced stages and even acute liver failure, which we'll go over. Clinical features wise for neuropsychiatric, neurologically, this kind of tends towards movement disorders or almost Parkinsonian-like symptoms with tremors, involuntary movements, drooling, dysarthria, rigid dystonia, pseudobulbar palsy, dysautonomia, but even more nonspecific things like migraines, insomnia, and seizures. Most commonly, as you can see here, that patients that when they do present at onset their neurologic symptoms, dysarthria, gait abnormality, ataxia, dystonia, Parkinsonism, postural tremor, dysphagia are the more common ones, as compared to less commonly chorea or resting tremor, as you can see, but obviously can present in a lot of different ways. Psychiatrically, this can present as simple as something as depression or mood disorder, neurotic behaviors, phobias, OCD, as well as personality changes that can sometimes develop in some patients, as far as being aggressive or antisocial, as well as psychosis. Was recently asked about a patient by one of my colleagues where they were considering Wilson's disease in a new cirrhosis, or some patient with cirrhosis and psychosis, which obviously can present in that way. And so outside of the liver and neurologic symptoms, you can have other clinical features that are important here. And on the left is going to be the classic Kaiser-Fleischer rings, or KF rings, which, while very important if present in liver-specific presentations, it's actually a coin flip if the KF rings are actually going to be there. And in neuropsychiatric symptom-wise, for patients that are considered for Wilson's disease, this is actually very important. 95% of patients that have neuropsychiatric symptoms from Wilson's disease will have Kaiser-Fleischer rings, which again are deposits of copper and discements membrane of the cornea. This is an important evaluation. Thing to remember, though, this needs to be done with a slit lamp, so this can rarely be done in the hospital, and commonly has to be done in the ophthalmology or optometry clinic. On the right here is another less common, but a sunflower cataract, so just kind of an interesting finding related to the to Wilson's disease. So outside of the eye and the neurologic in the liver, you can also get hemolysis, which is a Coombs negative process, so that's an important distinguishing factor. You can get aminoaciduria, nephrolithiasis, you can get osteoporosis or arthritis, cardiomyopathy, dysarrhythmias, pancreatitis, hypoparathyroidism, as well as menstrual irregularities, infertility, and miscarriages. So as you can see, this is can present in many different ways, and sometimes the patients have one or very few of these or many of these, and so it takes a keen eye and a provider using their clinical judgment to think about Wilson's disease when these come up. But obviously, we'll talk about we have to then know what to do to complete the workup and the next steps. While there are atypical presentations, really the classic Wilson's disease presentation is cirrhosis plus neurologic manifestations with Kaiser-Fleischer rings. This is most commonly in patients age 5 to 40, and about 50% of patients present with liver disease that lack 2 of these criteria. So again, a healthy degree of suspicion. I will also say that Wilson's age alone does not mean that it's not Wilson's disease. There are the rare case reports of patients in their 60s and 70s who are mostly defined by genetic testing as an asymptomatic person. But this is very rare, and majority of patients are going to be in between 3 and 55, or more likely in this 5 to 40 range. So now that we've had all of our training on what to look for, what to ask for, we go back and think about her case and the additional workup for her. There's no normal physical exam. She did get a slit lamp exam that showed no Kaiser-Fleischer rings, and her ultrasound showed mild hepatic steatosis with no cirrhosis or portal hypertension. And she had a very broad workup, which was ultimately negative, except for a low ceruloplasmin, very low ceruloplasmin, under 4. So we now have this patient with mild liver enzyme LFTs. She's 19. She has a mild history of anxiety and depression. Imaging showing hepatic steatosis without clear cirrhosis or decompensation, and her workup shows a low ceruloplasmin. So what are we going to do next for this patient? So this is important to know what you're going to do with that low ceruloplasmin. And so you can order urine ceruloplasmin testing, you can get serum copper testing, you can phone a friend, which is always an option, or call your local hepatologist. You could also just recommend lifestyle changes for MASH and repeat labs in a year. Well, I would say that's probably the one thing you should not do, is to just blow this off and say, oh, there's some fat in the liver, there's some mild LFTs, let's think about this later. I think with that ceruloplasmin, you really need to do the next step in testing, which we'll talk about here. And so what do we do with that ceruloplasmin lab when it comes back? Less than 20 is very sensitive, between 90 and 100% sensitive, depending on what study you look at, for identifying Wilson's disease. However, as with most highly sensitive tests, it's rarely then highly specific. And so 20 cutoff has been used as a marker for indicating additional testing, but it is not very specific. Once you get down more into the less than 5 range, it can be highly specific for Wilson's disease outside of some other rare conditions, which I put up there on that previous slide that cause low ceruloplasmin. However, one thing to remember is that normal does not exclude Wilson's disease. And that's because, and depending on the timing and the severity of the disease, and specifically in acute Wilson's disease, ceruloplasmin can be elevated as it can be an acute phase reactant as well. So a healthy degree of suspicion, if you have enough of those clinical features, to think about this additional testing if you're worried about Wilson's disease. As far as on other diagnostic testing, the serum copper is usually ordered as a total copper. This is commonly actually low in Wilson's disease, which can trip up a lot of people. And that's because the way that the lab works is that it usually uses the ceruloplasmin to then calculate the copper in the body. And so a low ceruloplasmin in a patient will then lead to a low copper level. However, it is significantly elevated in patients with acute Wilson's disease, which has a significant increase in unbound copper in the body. And so total copper is more commonly elevated in acute Wilson's, but can be low or commonly low in Wilson's disease, specifically chronic Wilson's disease. Thing to know about is the non-ceruloplasmin bound copper. This is an equation you can do or a direct test. So the equation is serum copper minus ceruloplasmin times 3. And so normal is going to be less than 15. However, elevated is going to, specifically above 25, is concerning for Wilson's disease, and over 200 in acute Wilson's disease. This is also elevated in other situations such as acute liver failure, cholestasis, and copper intoxication. And the thing to know about it well is it's notoriously unhelpful or inaccurate. And that's because a lot of times, again, the way that the lab testing is done to calculate this, it commonly becomes negative and is unhelpful in this situation. This is where some new lab technology has been developed, where it's a direct measurement of non-ceruloplasmin bound copper. And this is usually a specialized test with a send-out, and as specialized labs that really will accept this. So you really need to be getting this testing done at like a Wilson's disease center of excellence, or a place that has clinical trials ongoing for this. And so something that we will be bringing here through some work with one of our colleagues at Orphalon. And so we're hoping to be able to provide this to our patients soon. And as far as the next test after ceruloplasmin and serum copper testing and non-ceruloplasmin bound copper testing, if you have it available, is to do a 24-hour urine copper, which is kind of the most important next step after those screening tests. And that's because this is, as of now, for most places that don't have direct non-ceruloplasmin bound copper testing, this is the best way to assess for copper overload in the body. And so 24-hour urine copper is less than 40 points against this being Wilson's disease. Between 40 and 100 usually then requires additional testing, which we'll go through, or it requires additional testing to complete the workup. And greater than 100 strongly points towards Wilson's disease, the diagnosis of Wilson's disease, specifically in symptomatic patients. You can do this D-penicillin administration or test to show an increase in copper. I would say this is more commonly done in the pediatric population, but you may see this in the algorithms as far as working up these patients, but less commonly done on a day-to-day clinical basis. So we take this next step from this patient, and she got serum copper testing. As I explained earlier, it's commonly low. Remember, her ceruloplasmin was less than 5, and her serum copper came back at 13.8 micrograms per deciliter. Her urine copper, though, came back as elevated at 121 micrograms per 24 hours. One thing to remember with the 24 urine copper is you're specifically looking at the micrograms of copper per 24 hours, and also making sure that it's an adequate sample with checking the volume that was brought in to make sure that it's a full demonstration of a 24-hour period. So in our patient, again, further pointing, even though there's no Kaiser-Fleischer rings, the low ceruloplasmin and the elevated urine copper continue to point towards Wilson's disease in this patient. But do we have enough to really make the diagnosis yet? So do you just start treatment? Do you start, zinc or chelation, or do you get some more testing with a biopsy or genetic testing? And again, that phone a friend for your neighborhood hepatologist is available at any time. And so I would say that we still need more information before we make this diagnosis. And so usually the next step in this case for most patients would be a biopsy. However, we'll discuss genetic testing briefly in its role. So for liver biopsies in Wilson's disease, the histologic features can be very nonspecific. You can see steatosis, hepatocellular necrosis, can again look like autoimmune hepatitis. Fibrosis is common in patients. Even by the second decade of life, most patients would develop cirrhosis by that point. It's a macronodular cirrhosis, but not all patients will. Some will have minimal or none, depending on where the disease is affecting greater. And it's hard to know which patients will present in which way. Acute liver failure can also develop with apoptosis and parenchymal collapse. The more important part of this biopsy is the copper quantification, which is commonly a send out, excuse me, on the biopsy. Normal is less than 50 micrograms per deciliter, and Wilson's disease is diagnosed when the level is greater than 250. And this is really the gold standard for making the diagnosis for Wilson's disease is a copper quantification, excuse me, on a liver biopsy. That in-between area is important, and that's where genetic testing becomes helpful to kind of distinguish between how high our concern is to make the diagnosis for Wilson's disease. The other thing to know is that when you're asking your IR doctors, or if you're doing these yourself, is to do a second sample specifically for the copper quantification. And this should be sent off in a metal-free container to prevent excess copper deposition that might screw up the test. And so this should usually be communicated directly with your radiologist if they're doing it, or yourself, obviously doing it in a separate jar. So genetic testing, a lot of times these are more difficult cases where we're having trouble making the diagnosis, where we have some labs that are indeterminate and not convincing, and I'll show you an algorithm in a second. But again, there's more than 600 mutations of the gene, of the protein, and so there's a high prevalence of compound heterozygotes. And this again is recommended in these difficult patients. I'd say more commonly, what I've seen done for this is that the genetic testing is done to screen first-degree relatives or asymptomatic family members. And that's because all family members, once a diagnosis is made, should be tested to make sure that they aren't just asymptomatic. And I have plenty of examples of this where we've diagnosed a sibling with this, or a child once the parent or the sibling is diagnosed. And this is usually done through multiple different, we won't get into this, but having your genetics team help with testing and then counseling after that. So in our patient, she underwent a liver biopsy, as that was the next step based on the urine copper. And it showed active steatohepatitis with 10% macrovesicular steatosis and mild interface activity. It also showed portal and periportal and perisinusoidal fibrosis, which is stage 2 of 4, so not cirrhosis yet. And the copper quantification, as you can see there, was diagnostic for Wilson's disease with a level of 1500 by dry weight. And her genetic testing is actually still pending at this time. So how do we know? Have we now made the diagnosis? As I said, it's highly suspicious for and the gold standard, but obviously there's atypical situations, and so knowing how to make the diagnosis, this is usually done using the Leipzig criteria. And this uses a combination of all the things we've already talked about: Kaiser-Fleischer rings, neurologic symptoms and the severity of that, serum ceruloplasmin, degree of decrease, Coombs negative hemolytic anemia, liver copper quantification, urinary copper elevation, as well as mutational analysis. And Wilson's disease is diagnosed when this score is greater than or equal to 4. And so something to kind of puts all these factors together so that we can start learning the right steps and identifying features to then ultimately make the diagnosis with this criteria. And so in our patient, she had a Leipzig of 6. with increased urine copper, decreased ceruloplasmin, and increased liver copper quantification. So hers will likely be even higher score-wise once her genetic testing comes back. And so this patient, we now would say she is diagnosed with Wilson's disease. And this is from the ASLD guidelines and how they kind of approach unexplained liver disease, and then we'll go over unexplained liver disease plus neuropsychiatric symptoms. That really the main distinguishing factors of those three baseline tests we talk about, specifically KF rings absent or present, ceruloplasmin greater than or less than 20, and then 24-hour urine copper greater than or less than 40. And as you can see here, for unexplained liver disease, if the KF rings were present in this patient, we would have been able to make the diagnosis without the biopsy based on that left side of your screen. However, most commonly in liver disease does require additional testing, which is most commonly the biopsy, which you see there in the middle with copper quantification. Molecular testing or genetic testing really only comes into play when you end up in that indeterminate range. Really that's when it's needed to kind of make that diagnosis, which is not commonly needed, but can be helpful in these complex cases. And then at the bottom of the screen, as you can see, if the copper quantification is elevated or the molecular testing is positive, that then makes the diagnosis for Wilson's disease. Neuropsychiatric testing, again, like we talked about, the KF rings are really, really important for or very, very common, 95% of patients, and so more important for delineating concern for Wilson's disease. And so as you can see there, if KF rings are present, you can make the diagnosis of Wilson's disease, again, pretty easily. And you can actually, the big difference between the last screen and the last algorithm and this one is that in neuropsychiatric symptoms, if KF rings are present, you can make the diagnosis even with an elevated ceruloplasmin if molecular testing is positive. So you can avoid a biopsy in some patients. But as you can see here, though, while this looks complicated, this more or less states that a biopsy is needed for most patients, the quantification, and then using molecular testing if it's indeterminate or low to then decide if the diagnosis is made either by copper quantification or molecular testing. So KF rings, ceruloplasmin, 24-hour copper, and then biopsy or molecular testing are going to how you're going to get to the diagnosis here. So in our patient, she did not have Kaiser-Fleischer rings. Her ceruloplasmin was low, and she had an elevated 24-hour copper. And we got the biopsy, as you can see it there, with an elevated level. And so we made the diagnosis of Wilson's disease in here. One quick kind of discussion point is around acute Wilson's disease. Again, this is a different presentation where basically a massive release of copper commonly can lead to severe Coombs negative hemolytic anemia with acute intravascular hemolysis, coagulopathy unresponsive to vitamin K, and rapid progressive to renal failure. KF rings, again, are a coin flip in this situation, so the lack of them does not rule it out. Some things that are to know about in these patients, and you might be seeing these more in the hospital, in the ICU sometimes, or in the floor in the early stages. Ceruloplasmin is commonly low, but again, as I said, it has a decreased predictive value here. Serum copper is usually elevated, greater than 200 usually. Urine copper is elevated, but that takes time to come back. And have modest rise in serum aminotransferases. So this is typically less than 2,000 or commonly even lower. And something to know about these patients in general is that they usually have normal or markedly subnormal alkaline phosphatase, typically less than 40. And that's because copper can be directly toxic to the production of alkaline phosphatase. And so to the enzyme that creates that. And so the ratio that you can kind of calculate if you're thinking Wilson's disease in someone with hemolysis or acute liver failure is the alkaline phosphatase divided by the total bilirubin, and greater than 4. Less than 4 can strongly point towards acute Wilson's disease as the diagnosis. Because a lot of times patients are very sick and decisions need to be made quickly in these patients. So you don't have time to wait for all these testing to come back or get a biopsy. They might be too sick with the coagulopathy. Ultimately, the treatment for this is going to be transplant. These patients are listed status 1A, so above MELD score in that 500-mile range. They'll be the top patients there. And that's because this is universally fatal without transplant. Plasmapheresis can be considered, but it's just a temporizing agent or temporizing treatment to get to transplant. And so these patients are very sick. You need to identify it early. You need to know that your testing is less diagnostic and it presents in a different way. And these are patients who should be at a transplant center to be considered transplant early in this process. Something you can calculate is the new Wilson index, which score above 11 is a strong predictor of mortality without transplant. Uses, as you can see there, bilirubin, INR, AST, white blood cell count, and albumin. And so just to spend a second on this, just because transplant, we're trying to avoid it, but it is curative for liver disease related to Wilson's disease, and that's because it fixes the ATP7B. And you comes with new enzymes with the new liver that produces, as long as it's not from a Wilson's disease patient, but its disease is curative. So the new liver will decopper the body and basically cure the patient long term without need for any treatment, medical treatment, which we'll talk about. It's neuropsychiatric, and there's a lot of interest in research into this right now. The data is mixed. Only about 71% of people who have complete or major neurologic recovery with transplant, and you're unable to predict who will improve pre-transplant. So in the United States specifically, this remains a very controversial topic on transplant for neuropsychiatric symptoms for Wilson's disease, knowing that they might not get better and you're putting them through a transplant. I think this has to be done in very selective patients and knowing that they can understand the risk benefits, but I would say that this is not an indication for transplant commonly at most centers in the United States right now. It does, though, have excellent post-transplant survival at 3 and 5 years. As you can see, they're around 90%. However, there's lower 1-year survival in the acute liver failure patients at about 80% compared to chronic liver disease patients. So obviously, that's transplant. That's curative. The Wilson's disease is cured and it will eventually correct itself unless there's permanent neurologic damage from the copper deposition. But how do we prevent transplant? While transplant's a great tool, we have a lot of other tools that are available to hopefully prevent that from ever being needed. And so what is the next step for our patient? We're not going to run her straight to transplant, right? She just has some mild LFT elevations and some fibrosis. So what are we going to recommend for her? And so I think that the next steps for her, ultimately are to phone a friend. So this is the time where, while you might be able to find these things online or find the guidelines for treatment. While starting treatment is important, this is the type of patient that, though, we want to get to a hepatologist or a Wilson's disease center of excellence to basically initiate treatment as quickly as we can. But there's a lot of complexities and monitoring needed during this treatment process that I think is done better through someone who sees more than 1 or 2 of these at most in their career. And so this is where getting them to us, and I'll give you my contact information at the end, but I'm happy to expedite seeing any of these patients in clinic as fast as possible. If you have any suspicion for Wilson's disease or just need assistance in working them up, I'm happy to discuss anytime. So what are the next steps outside of phone a friend? So all these things are ultimately treatments that I will go through with the patient once they get here. Diet and treatment to decopper and prevent reaccumulation. And so a low copper diet is really important, less than 9 milligrams per day. This is really tricky, though, because there are no, if you look at your labels, there's no, it's just listed as like a trace element. So there's no basically way to quantify without going online and working with a dietitian who knows Wilson's disease to help identify diets that can help reduce the reabsorption of copper. And so as you can see here, there's some very common things, as I said before. And so fortunately, the Wilson's Disease Association, which is a great patient advocacy group and source of information, helped create the Copper Conscious Cookbook, which can be found on anywhere you find books usually. And it's a great way to then start building your diet in a low, but I would always recommend seeing a dietitian, which we have great ones here, and I refer all of my Wilson's disease patients to our dietitians. But unfortunately, you cannot treat Wilson's disease with low copper diet alone. And so that's where medications really become an essential part of treatment here. And the main classes that we'll use is chelation, as well as reducing uptake with zinc. Chelation, the medications that are FDA approved in the United States are D-penicillamine as well as trientine. I'll go through each of them. Trientine comes in two formulations, the dihydrochloride and tetrahydrochloride. The tetrahydrochloride is of now only approved for once they are decoppered for maintenance. However, there is a upcoming clinical trial, which will be a site for using this as a decoppering agent. So more to come on that as we get our clinical trial rolled out. And so it has benefits of being shelf stable and can be daily dosed. So a lot of benefits to that we'll explore once we get that going for decoppering. But as of now, the dihydrochloride and the D-penicillamine are your options. The other that you can do is to reduce uptake through zinc. This is three formulations: sulfate, acetate, and gluconate. And so Galzin or gluconate is the only FDA-approved medication right now for Wilson's disease for zinc. So we'll go through each of these. D-penicillamine is the oldest and best studied, commonly the cheapest and recommended on a lot of formularies from insurance companies. So you will be recommended to use this a lot of times to start. However, as you can see here, as a general chelator, which induces urination of the copper. And so fever, side effects of these medications include fever, rash, proteinuria, lupus-like reaction, aplastic anemia, leukopenia, thrombocytopenia, nephrotic syndrome. So there's a lot of things here, as well as some more rare ones that we need to monitor for. And starting this medication does require looking for things like proteinuria, watching blood counts, things like that. So you have to do it in a safe manner. The trientine, one of the other big differences between the D-penicillamine and the trientine is going to be the neurologic decompensation. So, and D-penicillamine, about 10 to 20% of patients have neurologic deterioration during the early period, and this does require monitoring. And so this is something that needs to be monitored closely, and is one of the more common reasons that D-penicillamine is stopped. When this happens, it can be really severe, and I've had patients like this. And so patients with neurologic symptoms at baseline, I tend to try to get them on trientine to start. However, insurance can be an issue for these patients. So it's also a chelator, which induces urinary excretion of copper. While there is a neurologic deterioration listed there, I think in real life this number is a lot lower. It also has less side effects and requires less monitoring as compared to the D-penicillamine, but does still have to monitor some blood counts and other things as you're starting it. Zinc is basically induces methanolamine that blocks intestinal absorption of copper. And so this prevents absorption. It doesn't decopper and remove it. So it just basically creates a net negative over time. Technically, the literature would say that there's some neurologic deterioration. I would say in real life, it's almost never, just given the mode of action and how it works. But it can cause some symptoms like gastritis, rarely pancreatitis. It can cause zinc accumulation, copper deficiency, as well as some changes in immune function. So zinc can have its own issues. It's also a 3 times a day medication, which we'll talk about, and has to be timed around food, similar to these other medications. And so medical treatment here for asymptomatic patients, you can use D-penicillamine or trientine, or you could consider starting with zinc. In truly asymptomatic patients, these are usually patients that are identified as siblings, and so these you can usually start a lower dose of these medications and divided dose. It's weight-based, or just start with zinc. In symptomatic patients, which is more common, you do need to do decopper, which can take 6 to 12 months. You can use D-penicillamine or trientine, and usually start at 20 mg per kg per day in divided doses. Usually start low and titrate slowly. Basically you don't want to push this too hard, specifically with the D-penicillamine, if there's to worry about neurologic decompensation. Maintenance-wise, you can then decrease to a lower dose or transition to zinc at that point. And as I said, the Transtine tetrahydrochloride is a good option for patients who are decoppered and want an easier dosing regimen and shelf-stable medication. Some special considerations that in pregnancy, it reduces D-penicillamine. You should reduce D-penicillamine and Transtine by 25 to 50% as well as in surgery. And then to know that these need to be timed around meals. And so your pharmacist is really helpful in kind of helping educate the patient on timing of all these. And it can get really difficult with these 3 times a day medications and dosing sometimes. So how do we monitor? We ultimately monitor using urinary copper excretion is the most commonly done now. However, as we talked about before, there is direct measurement if that's available at your center of non-ceruloplasmin bound copper can be used as an analysis for assessing free copper and effectiveness of decoppering. And so we still, for 24-hour urine copper though, we do recommend holding the chelation 48 hours before providing the sample, and that allows us for a better assessment of true copper levels in the body. And so as you can see here, you can use these levels for over or under treatment, and the treatment goal for D-penicillamine and Transtine is somewhere between 250 and 150 to get in that range. Once you start to go below that, that could be a sign that you have over decoppered the patient and they are now copper deficient, which has its own issues and symptoms and problems. And then zinc, you can see here, you're shooting for more in the 30 to 120 range there. So these are important because we need to serially monitor these to make sure that we're not over or under treating and making sure that patients are compliant and knowing when we can start either backing off or need to escalate dosing. So how does this medication work? What are we doing with this treatment? So by decoppering, we are preventing progression of fibrosis. We're preventing decompensations, and we are preventing a need for transplant, which has been shown, which are all obviously good things. So you can prevent this person from needing or having long-term complications of liver disease or transplant. And the basic life expectancy once decoppered without advanced liver disease is as a normal person. So you can get them their life back. However, they do require obviously lifelong treatment. There's some important transitions between the decoppering and the maintenance, which needs to be done in a coordinated way to monitor to make sure that we keep them at goal, don't overtreat them, don't undertreat them. As well as there's a lot of literature on the pediatric to adult transition, for which we have a clinic here or at Children's here where we transition the patients this way. But this can be very stressful and complicated and a chance to unfortunately lose a lot of these patients in between these transitions to adulthood, and supporting them through that process where they take on more of their own responsibility and treatment. Again, lifelong therapy is required. Diet is not enough to prevent disease. And then compliance and monitoring is key. So easy dosing regimens, good close follow-up, all those things are needed. Good relationships with the patients. So outside of the medication therapies, where's this field going? A lot of these are obviously in clinical trials right now, but some thoughts are for some current research is restoration of ATP7B function. This has to be kind of more mutation specific, but there's been some small molecule studies looking at basically repairing the ATP7B function of the native hepatocytes. You can do gene therapy. However, you have to develop a viral vector. However, some of these are in phase 1 and phase 2 clinical trials right now. You could use CRISPR to basically repair the enzyme. However, there's a large number of mutations to this at over 600. And so you need to basically create something available that could fix all these different mutations depending on what the person has. And then there is hepatocyte transplants where you transplant hepatocytes instead of a full liver. This does still require immune suppression, but this could potentially prevent the need for decoppering if the new liver cells again come with the ATP7B enzyme. So these are things that are all in clinical trials. None of them here right now, but something that can be explored with patients if they're having trouble with medications or looking for what's new and available in the field. So what about our patient? So our patient, she saw our dietitians and started a low copper diet. She initially started Transtine dihydrochloride, and her urine copper went from 850 to 450 to 130 over the course of about a year. This trend is consistent with her compliance and now decoppered. She had no neurologic decompensations, neuropsychiatric decompensations. Her LFTs normalized, and we recently switched her to tetrahydrochloride for ease since she's in college and travels. And I've had patients who've had to ask the stewardess to keep their Trientine cold for the flight and all these things. So it's nice to have options. And eventually, her plan is to transition to zinc once she comes back, eventually to and stable for long-term management. So overall, she's doing really well and tolerating the treatment really well. And so what are we talking about again today? We talked about identifying presenting signs and symptoms of Wilson's disease. We learned baseline Wilson's disease testing and how to interpret the results. And then obviously recognizing when to refer to a hepatologist. And these are the type of patients that are very complex. Sometimes it's subtle, sometimes the diagnosis is not obvious, and we're happy to see any of these, or I'm happy to see any of these, our colleagues as well. So feel free to reach out anytime. Here's my references. And again, any questions, and there's my contact information. Feel free to reach out, either email or just text me or call me if you ever have any patient you want to run by me. But thank you. Um, Looking here, I'm just going to check the chat.
Looks like there's just one question in the chat, Dr. Rice.
Sure. Let's see. Thoughts on transplant for neurologic symptoms for Wilson's disease. It's a great question. I have a patient specifically who did decompensate with starting D-penicillamine therapy. She's doing much better right now, but has had a really rough year plus with that. I think the way that I think about this, as well as a lot of these new therapies, are what is the superiority to the medications that they're already receiving? And I think the studies need to, in my opinion, prove that the outcomes are superior to the medications. Or a patient has to have a reason strong enough to take on something like transplant to benefit from the transplant or the clinical trial, or if someone's tolerating their zinc or their Trientine or even the D-penicillamine, or why would we switch things to something that has risk like a transplant or a clinical trial, unless their goal, they needed to get off medications for a certain reason, or if these trials prove that they're superior, so clinical outcome wise. And so I think that's really the next steps before I would start recommending neurologic transplant, is why are they not tolerating the medications for a certain reason? Then maybe we should consider transplanting these patients because it might be their only option. But as far as just, it might work, I don't know why it should work better than medication. And so I think that it's needs to be investigated further before I would strongly recommend it for all patients. A great question, Avash. All right. Well, unless anyone has any other questions, obviously, again, my information is there. Please text, call if anything you need to, just let me know. But here's for CME. Feel free to fill this out. And then again, another pitch for the Rocky Mountain Highlights. I think it's a great conference, and I encourage you guys all to go, and it's free. So thanks for listening.
Thank you, John. Thanks everyone for joining.